Welcome and shalom to all my colleagues and friends in Israel. I bring you greetings from Columbus, Ohio, here at Nationwide Children's Hospital. I'm thrilled to be able to present today the art of respiratory care in Duchenne and Becker muscular dystrophy. And I like to use the word art mainly because every patient is different. And it's really an art to really get to know you and your families and what type of care your child needs as we move forward with this disease process. But I wanted to start with just talking about the breathing muscles, because when I talk to these kids in clinic, everybody's so focused on the wheelchair, if that's needed, on the leg muscles and things like that. And my focus is really to remind these children and young adults that there are hundreds of breathing muscles that are affected. And we'll go into this a little bit more, but I look at some of these devices that we can use as the wheelchair for our lung muscles, and really trying to keep them strong and have an effective ability to clear secretions when we need to. But as mentioned, there are lots of muscles that are affected from a breathing standpoint as well. But we also focus on 4 respiratory stages when we look at Duchenne and Becker. And obviously Becker is a little bit more mild, so I am going to focus more on these stages in Duchenne. But initially, we have normal breathing and we have normal pulmonary function. When we see children in clinic, we are doing lots of practice blowing into our pulmonary function test machine. We are kind of monitoring different values to see when those children start getting weaker. And we see this initial stage from birth until age 10 or so. And these numbers are not exact, but we also see in this next stage in the early teens still normal breathing, but we might see a little bit weaker cough, and we might see a little bit more of a decline in pulmonary function. That third stage, we see normal breathing during daytime, but sometimes we have what we call hypoventilation or shallow breathing at sleep. And this is something that we really also need to monitor, and we see this more in the mid-teens. Really, as people start losing ambulation and are using wheelchair more, this is when doing pulmonary function tests and really focusing on the respiratory disease part of this is really important. And then that fourth stage, we have weak breathing during wake and asleep, and this is really more of the end stage of this process. And we do everything we can to support people and keep those lungs clear. I have this slide in here because this is what my brain looks like when I see a patient in our neuromuscular clinic. When I walk into a room and I see someone in a wheelchair, my brain all changes to ask specific questions because I can see what stage of the disease is. I may ask what change of muscle strength that we've seen and what your stamina is. But I also talk about eating, like, are there any symptoms that you notice with chewing or swallowing? Is there any choking? And nutrition is so key to your whole body in general that it does play a role in respiratory health as well. But then I also talk and focus on sleeping. Are you waking up with headaches? Are there behavioral changes? Do they wake up a lot? I think that if there's a significant change in behavioral symptoms while you're sleeping at night, that's something to talk about with the doc in clinic. And then obviously breathing, like looking at your pulmonary function and your cough strength and the history of whether or not you've had any infection since we saw you last. But I'm going to focus the rest of my talk really on going through what we do in clinic from a respiratory standpoint and what should be followed based on our guidelines, at least here in the United States. You know, first, from a respiratory standpoint, we do pulmonary function tests. This helps us track those changes. And this can be a difficult test for someone without neuromuscular disease. So it really takes a respiratory therapist or another therapist who's more of a cheerleader to get some of these young kids to blow appropriately. And we do have adjustments to the mouthpieces so that, you know, people who have more weaker cheek and mouth muscles can get their lips and tongue and teeth around this. But the terms you really should know about are the forced vital capacity, the mean inspiratory pressure, the mean expiratory pressure, the cough flow, and what the carbon dioxide levels are. And these are really the 5 main things that when I send someone to the pulmonary function lab, these are the things that I'm going to discuss. And most research is based on that forced vital capacity and the cough flow. And these numbers do help us provide some guidance as to risk with anesthesia if you're going to have a procedure done, or it also helps us guide us as to the next step. Do we need to do a sleep study? Do we need to prescribe any additional therapy? So if nothing is taken away from this conference, this is the most important slide, that chest therapy to me is the most important and preventative therapy you can do when your muscles are weak. You can't clear the secretions. So I look at this device. This is a Respiratory cough assist, but in my head, it looks like a wheelchair. And if you use it appropriately and you clear those secretions, things are really going to work really well and move ahead and keep those lungs clear and those muscles as loose and your lungs as open as possible. And I think it's very important to do this every day. I do look at it as preventative therapy, almost like physical therapy for your chest muscles, but it's a device that when you do need it because you have a weak cough, you can use it to clear the secretions and prevent ER admissions, prevent pneumonias, and really help clear those secretions. And I believe it keeps your lung function more stable, but I haven't been able to prove that yet. This cough assist, other ways to clear secretions, some people do manually assisted cough. Some people are taught to do an abdominal thrust with a deep breath and then use an ambu bag to help them take a big deep breath and cough. It's really important. The cough assist just gets your diaphragm to the right spot so you can have an effective deep breath and cough as clear as you can. And so we tend to, when your cough flow is around 260 liters per minute, based on your pulmonary function test or based on clinical symptoms, I will usually go ahead and order that for my patients here in our clinic. I throw this in here too. This is the vest. This is a device that helps shake mucus loose. It was approved for diseases like cystic fibrosis to help them mobilize their thick secretions. In Duchenne and Becker, we don't have thick secretions. We just have a weak cough. So the secretions are normal. It's just hard to get it out. So I do believe that the vest is helpful for people who have recurrent pneumonias. And sometimes we add that in, but if I had to pick one therapy, the cough assist makes more sense to me because it doesn't make a lot of sense to shake things loose if you can't clear your secretions. So people that I use the vest in always follow a vest with a cough assist. Scoliosis plays a big role, and there's very good evidence from a respiratory standpoint that if we correct the problem from a surgical standpoint, these patients do better overall, especially if we combine it with other respiratory support like the cough assist or BiPAP. We have not been able to prove that scoliosis surgery does improve pulmonary function, but patients do live longer and they have a better quality of life. It's just very important to work with the pulmonologist and the neuromuscular doctor as well as the orthopedic surgeon to pick that perfect time to do surgery if scoliosis surgery is needed. The other thing that we talk about a lot in our pulmonary clinic is looking at their sleep. So do patients have behavioral changes? Do they feel tired? Are they waking up more? Do they snore? Are there headaches in the morning? Headaches in the morning sometimes mean that your carbon dioxide level could be elevated because you're breathing more shallow at night. And we also look at the declining pulmonary function. So I take all of these into account before I order a sleep study, but this picture just kind of talks about, or shows what's happening during a sleep study. But it's very important with neuromuscular disease to get a sleep study where we're monitoring the carbon dioxide level, because we're looking for hypoventilation as well as apnea that some children and adults do have. If the sleep study shows that we need support, we have two different types of support. We have non-invasive ventilation, which is BiPAP. This helps you take a big deep breath in, and it also helps keep your lungs open. And overall, it helps people breathe easier and take a more normal breath at night. But there are some patients that BiPAP, when you use it for more and more hours during the day, they choose more invasive ventilation. And there are some patients who choose to have a tracheostomy tube with a ventilator connected to that. But overall, my bottom line is really to talk about all these things when you come into clinic. Tell us about any breathing problems that you have at each visit, and call if this happens in between visits. I believe in getting pulmonary function testing done at least yearly, and we usually start that when patients are about 5 and able to understand what they need to do with that test. Watch your weight and nutrition, because that, being overweight can affect your breathing. And nutrition can lead to also constipation issues, which if you're constipated, you're gonna not have your diaphragm work as well. I always talk about having the supported home that keeps you out of the hospital. And when you get that supported home, use it daily. Discuss issues with your docs about your back or your spine at these visits. Talk about how you're sleeping with each visit as well. And we'll get sleep studies when we need it based on those symptoms. And I think it's very important to have an emergency plan in place so that if you do end up in the emergency room, you know what to tell those doctors and nurses and therapists, what type of things that your child or your adult, if you're an adult, you can tell them what you need. But finally, I like to end with this slide, because this is really how we look at our pulmonary. My pulmonary involvement is just part of a team in clinic. And as a patient and a family, you are at that center of the clinic. And we really profess this multidisciplinary role. So I think this kind of shows that everybody can go in and see the family, but we're all interconnected outside. And having that conversation really helps with understanding where a patient is in the disease process, and having good communication amongst that team really makes that therapy better and more successful. So with that information, I know that was a lot to put into a very short conference meeting. However, I appreciate the ability to be able to present this to you, and hopefully this will open up questions when you see your doctors again. I wish I could do this in Hebrew, and I wish I was live in Israel with you right now, but my very little Hebrew school does not permit me to do that, since that was a very long time ago. But I hope to all meet you at some point in the future, and I'm always happy to take any questions.